Assalamualaikum warahmatullahi wabarakatuh, and very good morning to MSQH CEO, Professor Dato Dr. Rahim bin Abdullah, MSQH Technical Advisor, Associate Professor Dr. Kadar Marikar, MSQH Executive Manager Ms. Noramiza, and MSQH staff, and all participants. Before we begin, let's start with doa recitation. Al-Fatihah. Yeah. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi washabbihi ajma'in. Allahumma inna nas'aluka bi annaka antallahu ahad, as-samad lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Allahumma iftah alaina himmataka wa ansur alaina min khazaini rahmatika ya arhamar rahimin. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Amin. Amin rabbal alamin. Okay, so I think everyone is ready. So before we start, I will share you a bit of our agenda and also today's agenda, and also some of the housekeeping rules. So welcome to our introductory briefing on the new 6th edition Hospital Accreditation Standards. It's a free webinar for hospital and client facility. Our speaker is Professor Dato Rahim bin Abdullah, CEO of MSQH, and Associate Professor Dr. Kadar Marikar, our technical advisor, and lastly is our executive manager, Ms. Noramiza, Nasir. So this is our agenda today. So we will start at 10 where Prof. Dato Rahim for the welcoming remark, and about 10 minutes. Then we proceed to Dr. Kadar for the topic is what is new in 6th edition in MSQH Hospital Accreditation Program. Then at 11, 6 we have Professor Abdul and Ms. Noramiza will present to you about 6th edition MSQH Hospital Accreditation Survey process and administrative requirement. And 11:30 we have our Q&A sessions. So and we will end by 12 p.m. So this is some of the housekeeping rules. So duration is 2 hours. Today is 2 hours. 1.5 hours is our presentations, and half an hour for Q&A sessions. This webinar is being recorded for future viewing. The recorded version will be available in our MSQH Facebook, official Facebook. So you can visit later. So to ensure the smooth flow of our webinar, participants are requested to mute your microphone during the presentation by the panelists. If you have questions, you can put on the chat box. You can see your chat box. You can put your question there. MSQH staff will compile this question, and we will discuss it during our last agenda and during the Q&A sessions. And before we end, please fill up the feedback form that we will share you by QR code or by link in the chat room. So I will accordingly inform you. Okay. So without further, so I will stop share. Okay. So without further ado, I will invite Professor Dr. Rahim bin Abdullah for the welcoming remark. Boleh unmute Dato'
Thank you, Aiman, for the introduction to the today's webinar. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, selamat pagi. I'd like to welcome everyone who have joined us today, whether through Zoom or on the Facebook. Yeah. Thank you very much for joining us for today's introduction and briefing on the 6th edition national and accreditation program and the standards as well. Right. This morning we'll be looking at the overall program and then focusing on the standards. It will be, as the title says, it's an introduction and a brief. We'll be doing a centralized training on the 22nd of September, where it is a two days training, 4 hours for each day on the 22nd and the 23rd, where we will look in more detail at the changes, the new standards or criteria that we are looking for during the accreditation survey process, right? So that will be on the 22nd to the 23rd. Total of 8 hours, about 8 hours, 8 hours briefing on the actually briefing, discussing in more detail about the standards that we have made, the changes or new ones as required by ISQA, IEEA for their new edition. So that we can meet their certification for international certification by ISQA. I would like to just generally go to the background of MSQH. You know, our health system is basically divided into the delivery structure, the financial structures, and the intermediary structures, right? Each of those structures play an important role. Together, they play an important role to ensure the provision and delivery of healthcare meets to the goal that we share together, particularly in terms of the outcome, quality outcomes, and safety, both for patients as well as our healthcare workers. MSQH is one of those intermediate structures where our role is to play the role of being an oversight, professional oversight, as well as an enabler, educator, right, as well as evaluating. So MSQH is a professional peer review organization, right, that look on the more on the professional and the technical, clinical aspects of the running of healthcare facilities and their services, right? And and hope that this role will ensure that the main scope of healthcare facilities and services, such as hospitals, are focused on patient care. Patient care is right. Okay. So in the past, government plays all the role, but now the delivery, the private sector plays a very important role as well in Malaysia, in our country, and there are other organizations, intermediate organizations, in terms of delivery. I'm talking about the delivery that play their role. There are also many organizations that plays their part, like MSQH, to ensure that we are able to assist and facilitate the provision and delivery of healthcare towards better quality and better outcome. Towards medical and excellence as well as service excellence, right? Okay. So I don't want to drag on too long during the welcome. I'll be coming back later on, talking about the survey for this process on the 6th edition with Ms. Noramiza later on, right? The bulk of this today's webinar will be by Prof. Kadar, the next speaker, right? And and I hope some of the things that are going to be brought out, we are going to actually discuss in next week's accreditation committee, our national accreditation committee, to look into some of the things that we are thinking of, right? And confirm it during our centralized training on the 22nd and 23rd September. Okay, so the 6th edition is going through the national consensus now, and hopefully by November or by end of the year, latest December, will be certified, accredited by IEA as a standard of international recognition. Okay. And hopefully by next year we will implement it. But the training for this 6th edition, we will start as soon as I said just now, as soon as we can, all right? Starting with the centralized training on the 22nd and 23rd September. So without further ado, I pass back to Aiman to introduce Prof. Kadar. Right. Thank you very much. And thanks again for joining us on this webinar. Thank you very much.
Thank you for the welcome remark, Dato. So next, I will invite Associate Professor Dr. Kadar Marikar to continue our sessions today. So Dr. Kadar ready ke?
Okay.
Okay. Untuk boleh share screen ni. Minta IT highlight Dr. Kadar.
Assalamualaikum and a very good morning. Thank you, Aiman, for the remarks. First and foremost, before I start presenting the whole 6th edition hospital accreditation program, I would like to take this opportunity to thank all the MSQH members, participants, representatives from the various professional bodies, experts, MSQH surveyors, and all those who have contributed to the success in the reviewing, updating, and also introduction of new sets of service standards for the 6th edition, which we will be presenting today. And we hope we are, as the CEO have mentioned, currently we are in the final process for acquiring the national consensus, which will end by 27, hopefully. And we also take this opportunity to thank all those who have given the feedback on the 6th edition standards. This time, I think we had an enormous amount of feedback and further inputs, which we highly appreciate, which we will be discussing it on the 1st of September with the accreditation committee to finalize the whole set of documents before we actually present that in the subsequent training on the 22nd and 23rd of September, and also for finalization to the ISQA standards assessment and by 27th of September. So hopefully we need your support to also provide inputs on the survey that we're going to do, that we're going to have it available for all of you to give in feedback and inputs, further feedback and inputs to the philosophy framework that we are going to present, as well as the standards and changes that we are going to undertake in the 6th edition hospital accreditation program. So with that, I would like to also invite you to take the opportunity to attend the 22nd, 23rd, for you to further understand in details, especially on the changes in the 6th edition standards. Okay, today we are going to discuss about the whole program, where standards is one of the things that we're going to talk about, touch briefly. And with that, can I proceed with the first presentation? This is the outline of the framework of my presentation. I'll be talking about the philosophy framework, changes in the 6th edition.
Betul ada share screen ke? Betul ada share screen ke?
Okay, I just have a look. Share screen option. Okay, that's done.
Ya, dia tengah dulu.
Is that okay? Belum.
Dia tengah buka. Ya.
Still processing, yeah.
Dia still processing. Okay. Dia tengah. Okay. Doktor stop share dulu, Doktor.
Stop share.
Doktor stop share dulu.
Okay.
Doktor stop share dulu. Doktor dah buka dah. The presentation tu dah buka dah. Doktor jangan buka slideshow lagi. Doktor buka yang untuk edit tu dulu. Nanti baru masa dah share screen baru tekan yang slideshow tu. Doktor buka
Okay, now share screen
dapat baru tekan share screen.
Share screen, okay, share.
Sebab tadi saya rasa sebab doktor buka dah yang the slideshow tu.
Dah.
Oh, tak.
Dah. Okay. Alright.
Doktor, nampak lain ni doktor. Saya share kat doktor lah. Saya share tu, doktor share screen.
Okay, you manage.
Okay. Doktor stop share dulu.
Stop. Okay. So you will control for me,
Ya. Saya akan.
Okay.
Sekejap
Sorry for that.
Sekejap ya.
Okay, continue talking, Kadar, while waiting.
Okay, I'll be talking about I've given you the framework. So basically what we are going to share with you is a review of the 5th edition hospital accreditation program, inclusive of the standards. So there are a few changes that's going to take place, which we are going to share with you today. Aman, can we go to the next slide?
Ya, kejap tu dia tengah buka. Baik ya, sekejap ya.
Now, the major changes will be not as many, but we have actually sat down, reviewed the 5th edition standards. We have got several workshops. Some of the workshops have been done virtually. We have identified all the expert groups, the working committees. Some of them met virtually. Some of them came down to the workshop that we have conducted. We have had conduct two workshops. And in fact, this is one of the most longest duration of preparation of the standards because of the challenges we face with the current COVID-19, frequent lockdowns, and things have been quite delayed. So in fact, the 5th edition implementation has also been extended. And in fact, ISQA has also granted us another extension of our international certification for the 5th edition standards until next year as well. So, but we still insist that we would like to finish off this review. So we actually almost at the final stage now for submission of the 6th edition standards for international certification, and hopefully by January 2022, we should the 6th edition standards will be available for implementation, and as we have been planning for. So basically, the philosophy of the whole accreditation program, especially for hospitals, have not changed. It is still an external a peer review process, and we focus a lot on educating our clients, trying to change their mindset, creating a quality culture, and also ensuring that we have got continuous quality improvement within the services that we deliver to our patients, as well as at the end of the day to enhance a patient's safety. Now, the implementation strategies, if you notice, now we have got 5 E's as compared to the previous 3 E's. Previously, we have been having the education, enabling, as well as evaluation. Now, what we have added on is to actually address or provide more focus engagement with our clients, as well as empowering them. If you remember, the initiation of this whole accreditation program is actually, the intent was actually to self-regulate healthcare providers. So this is where the empowerment comes in. So we would like them to actually get the knowledge from us. We'll tell them what needs to be done, how it should be done, and what are the changes as we progress to ensure quality improvement is being in place, and we continuously improve our services towards excellence, so that quality will be sustained throughout the whole process, not creating ups and downs in our quality effort. We only provide focus to quality when the time for certification comes, but after you get yourself certified, everything goes back to square one. So that's not something that we are looking for. We are looking at continuous improvement in your services, and the mindset should be there to ensure that at all times, safe care, safe processes, safe services should be delivered with a safe outcome, and promoting or trying to make sure that we can save as many lives as possible. And especially now, I think with the COVID-19, we are having great challenges in trying to change, trying to achieve, trying to save lives, and in spite of the inadequate resources that we are facing currently. So I think these are issues that have given us or enlightened us what are the things that we should really prioritize in our healthcare system, in our services as we move forward. So that's where I think we are looking at providing that empowerment, and we hope hospitals, healthcare providers, our clients should get themselves equipped to ensure that they have got champions within the hospital to actually move this whole agenda forward, to ensure that safety would be one of the main issues that needs to be prioritized and given the resources to support the whole healthcare services, healthcare system within the nation. And at the same time, we would appreciate more of our peers, expert people to come in, expert consultants to come in to provide their inputs towards promoting good clinical governance within the whole framework. When we started doing this whole accreditation program in 1997, 98, 99, I think the then DG actually provides support, and that's where actually we have an MOU with the Ministry of Health to support MOH staff, clinicians, consultants, to provide the clinical governance leadership to this whole program. And that is highly appreciated, and would like to see that to continue to support. Without the support of the consultants, the peers within the whole healthcare system, it's going to be a challenge for MSQH actually to move the whole agenda for the whole healthcare, to improve the whole healthcare system within the nation. So I hope the intent and the MOU to be refreshed with the Ministry of Health. Now, at the same time, I think values is something that we need to actually also give priority. This is a healthcare system. Most of us are healthcare professionals. We do have a code of conduct, and we need to abide by this. I think here as healthcare professionals, the first thing that we need to think about is causing no harm to our patients. So this is where the code of conduct it's important for us to abide to in whatever we do. Patients should be our focus, should be central to the theme of our day-to-day activity. So creating a safety culture, and this has been one of the values of MSQH, providing integrity in the services, professionalism, patient and people-centered, as well as teamwork. We don't work alone, we work in teams. That's where I think the strength of MSQH currently is actually a teamwork between private, public, professional bodies. And this is very important to sustain, to ensure the continuance of this whole accreditation program in the country. Now, let us go to the quality framework, where quality in healthcare have got a few specific dimensions. It's not similar to any other services. Here, we focus on safety of the staff, safety of the environment we work, safety of the facilities, the structure. That's very important. Importantly as well is the competencies of the providers, the staff, the technical people, the technicians, the consultants. Their competencies is important, and this must be continuously being addressed. Training, continuous training, education is a must. I think all of us as healthcare professionals, we do have to fulfill our APCs. We need to have our CMEs, our credit points, and this must be a continuous effort by healthcare organizations, by the leaders of healthcare facilities and services. You need to provide that support, that education component, so they are constantly being educated, updated with the most current practices, best practices. So I think that needs to be addressed. At the same time, ensuring good access and providing appropriate care is important, and equally important is being responsive to the needs of the patients. The operational model that we adopt is the Noramiza model. This has been there since the start, and these have not changed. We continuously adopt this principle, and this is international everywhere around the world. When we talk about quality, this operational model has been adopted and recognized. Structure, looking to structure, process, and outcome. So I think these are some of the issues that we should address in the structural component of our services, and the provision of the currently, especially for hospitals in Malaysia, the Private Healthcare Facilities Services Act actually provides some of the major structural requirements that needs to be addressed by all healthcare facilities within the country before you actually deliver your processes. So I think that's fundamental, that's very important, and I think not many countries have got that requirement. I think Malaysia have got it in place, so I think we need to adhere to it, comply to it. I think there's no two ways about it. So these are our basic requirements that needs to be met by all healthcare providers. Even public hospitals are required to subscribe to the needs of the Private Healthcare Facilities Services Act 1998 and its corresponding regulation 2006. So that's very important. I think the Minister of Health is working very hard to ensure that they actually also subscribe to the requirements of the Act. Then the processes, I think all of this is something that keeps on changing every day, because medical technologies and medical knowledge keeps on changing. So we need to accommodate all these changes to make sure we have got the current best practices being practiced at our delivery points. So, and that's the reason why training, education is important for all healthcare providers. And that's the reason why we have actually now made sure that all consultants subscribe to the National Specialist Register. We need to put credentialing, privileging processes in place, and make sure that it is not just on paper, but is being implemented, operationalized at the site where care is given. So this is very important to make sure that we got the right person with the right knowledge performing or delivering the services, doing things right at the right time, the right place, in the right environment. So then we look at outcomes. So what are the outcomes? We need to know at the end of the day, what have you achieved? Have you achieved what you desired? Have you done anything harmful to your patients? If you do have complications, what are you going to do about it? Do you address it? Look at the root cause. What was happening? What can I do better? How can we improve our processes to ensure that we achieve the desired outcomes? So this is what is most important at the end of the day. We need to save lives. We need to minimize the sufferings of our patients. So there are functional perceived outcomes that needs to be addressed. At the end of the day, patients want to have the best experience. They want to make sure that they're satisfied with the service. So we do keep on getting this feedback from our patients, I think the requirement currently in the 6 monthly patient satisfaction or patient experience needs to be documented, and we need to make sure that we address it accordingly. Now, looking at the other component, the other aspects of care, the technical, the interpersonal, as well as the amenities. This is also the Norwegian principles in addressing healthcare. So we can actually look at some of these requirements and the technical aspects, as well as the interpersonal. This is where the interface between the provider and the patient. And this is where you talk about patient's experience, patient satisfaction. So you can actually measure and get inputs from your patients. And I think patients are very knowledgeable now. So they immediately give you the response, and they also can provide inputs to further improve your services. Hopefully with your regular 6 monthly patient experience or patient satisfaction surveys will help you to further improve your services to your patients. So at the end of the day, you can see that you can create this matrix, 4x4 matrix, looking into the quality aspects of your services, looking at the structure, process, outcome, technical procedures, your interpersonal relationships, your availability of amenities, aspects of quality. So all these processes and outcomes are measurable, and we can do that. Whereas in healthcare, when we say that we want to achieve excellence, when you say that you want to achieve excellence, it actually means that it is something that is measurable. So this is where we actually, as Donald Berwick said, the pursuit of improvement requires measurement. And this is where we have actually introduced measurement systems within our healthcare services, where we have actually now identified performance indicators. We are more concerned about having quality indicators rather than quantity indicators, but we do need quantity indicators because sometimes that actually determines whether you're providing quality care. So these are indicators that every services needs to address. So in our standards, I think from the 4th edition onward, we have already introduced this, and this is continuously being addressed in our current 6th edition standards. And we are trying to introduce targets so that people achieve a certain target. If you don't achieve, you need to relook at your whole processes. What has gone wrong? What can I do better? So these are some of the areas of concern that we can help to actually look at our problems, our processes to improve our outcome. So here, at the same time, monitoring of incident reports is vital. This is part of the whole healthcare system. We need to learn. Sometimes things that have gone wrong, we need to document. We need to understand why it went wrong. Have we done a root cause analysis? Have we identified what are the things that we should improve so that we have better outcomes? So all these are part of the whole process of continuous improvement that needs to be built in the whole system. So this is the cycle that you need to go through. If you have got a performance indicator, you have not met the target, this is the process that you need to go through to make sure that you can further improve your outcomes. Now, in accreditation, there are two things that we'll be looking at: the organizational quality. One is the corporate governance, and the other one is the clinical governance. In accreditation, however, I'm not saying that corporate governance is not important. It's equally important. You need to have your mission, vision, objectives, and goals, and also making sure that you have got structural requirements that provides you or ensures that you can deliver the services. This is where you need to comply with the requirements of the Act as well as the other 29 other related healthcare acts and regulations that needs to be addressed. What is more important in our accreditation program is the clinical governance, the way that your clinical services are being delivered to your patients. You need to be accountable to the services that you provide. You need to have a continuous monitoring system, continuous improvement in your services so that you can justify, you can provide the evidence, you can actually overcome some of the problems. Well, I think one of the things that healthcare providers need to recognize, patients of today are very knowledgeable. If they're not happy, they may drag you to court. So are you ready to make sure that you can stand in court? So documentation of whatever that you do to your patients, educating, explaining, sharing, being transparent with the services that you deliver to your patients is important, and having all this being documented in a system, in a process, whether it be computerized or manual, is important, making sure the right information is being kept and has been shared to your patient so that in the event you have got a medical legal case, you can stand in court. You can win the case. If we look at through the experiences we had over the years, I think in most instances, we lost quite a number of the cases due to poor record keeping. So this is very important. So healthcare providers not just deliver services, but you need to document and make sure you have got the right information, that what you have done, what you have provided to your patients being kept correctly as well. Now, at the end of the day, the accreditation of healthcare facilities and services is actually a demonstration of how accountable you are to the services that you provide. So it's a tool to measure your accountability. Now, in accreditation, the strength of the whole accreditation program lies in the standards that we use. And this is a requirement, international requirement, that we need to review frequently, regularly update our standards that we use because of the nature of the healthcare system, healthcare services, nature of the knowledge, the technologies that are being used within the healthcare services. It keeps on changing. It's very fast. So we need to be current. So that's the reason why the standards need to be changed, to review what we are practicing now is every 4 years we change. Now, since inception, we have changed. This is going to be the 6th time we have reviewed our standards. So that will have to continue. And that's where the excellence lies within the healthcare services. The standards pushes you to do things better and pushes you towards excellence so that we can continuously contribute to the provision of high quality and safe healthcare services to improve the outcomes of our patients. Okay, so I think those are the goals, important goals that we need to look at. Now, the MSQH Hospital Accreditation Standards, if you look at it, this is our history timeline of what we have gone through so far. So every revision, 3 to 4 years, and since the 3rd edition onwards, we have been getting international certification, and this is a continuous effort for MSQH Secretariat to deliver the best service standards to our healthcare providers, to our clients, so that you can provide, we can help you, to support you, to provide the best standards for you to subscribe to so that you can deliver and get the best outcome from your services. So the working definition of accreditation has not changed, it's still the same. And what we look at is the standards and your performance, and that element of continuous improvement is that these 3 things keeps on changing. So the outcome based on the standards. So every time you actually are moving up the scale to a higher level, to the next level. So you keep on getting better and better. The roadmap, this is, I think, has also not changed. So you need to be minimum for entry, you must qualify or you must subscribe to the requirements of the Private Healthcare Act and 29 other health care related acts. And then your prerequisite is to do before you get yourself certified by MSQH, you need to conduct your self-assessment. That's where we come in to provide you the support. This is where we'd like to enable you and engage you to ensure that you understand what is required, put things in place. We empower you to put everything and get yourself to verify what you do and then submit to us what you have achieved based on the standards, the criteria that have been set, the evidence that have been set, to tell us, to show us that we can certify you that yes, we can recognize you, you have completed, you have complied to the standards requirement, and you deserve to be accredited. Okay, so that's the
sorry to interrupt. Sorry to interrupt, Doctor.
Yeah.
We are moving lagi. We have more around 20 minutes. Doctor, pada slide mana ni? Which slide you want to further?
Never mind, I'm controlling myself.
Saya yang boleh control. Doktor tak ada control tu.
Ya ke? Now
yeah.
I'm on focus on patient safety.
Yeah. Okay.
Are you on the focus?
Doktor nampak dah slide.
You mean to say I'm not seeing your screen?
Yeah.
Huh? Wow, I'm talking and you're showing this different screen. Sorry for that. How do I get it correct?
Wah, Doktor sekarang ni saya dah share screen. Doktor tak nampak share screen saya ke?
No, I don't know which one.
Wan, tolong Wan.
I'm on focus on patient safety now.
Doktor buka Zoom balik.
Huh?
Doktor buka Zoom balik.
Zoom balik? You mean keluar?
Bukan keluar. Sekarang doktor tengah tengok slide doktor kan?
Ya. Yeah.
Doktor tengok dekat Zoom. Aiman ada share doktor punya slide dekat Zoom. Aiman is fully control your slide now.
Okay, Doktor start share screen Doktor. Okay.
Dah betul dah.
Ni Doktor punya slide kan? Okay, ni Doktor yang share. Okay. So Doktor tekan slide show dulu Doktor. Doktor tekan slide show kat bawah tu.
Full slide show.
Kat bawah kanan.
Okay,
okay.
Dah.
Okay, tekan tu. Okay.
You should go back, should go fast. Betul, sekarang the screen is
sekarang Doktor yang control screen.
Saya yang control, okay.
Okay.
Sorry audience for the interruption for the technical issues. Okay, I'm here at focus. Now, the focus of the whole accreditation program is still on patient safety and staff safety. So it's actually a risk reduction activity. The underlying principle is that when healthcare organizations meet or surpass the required accreditation standards, and errors and adverse events are less likely to occur. So these ensure safer service. This is the main principle behind the whole accreditation program. So we actually, when we are on site or when we conduct the surveys, it is actually just a snapshot of your 365 days. So we hope to see things are well in place based on the standards. And we also sincerely hope that whatever that has been put in place is being addressed every day, not just the day that we are on site. Okay, now let's move on to the 6th edition standards. So what are the changes? The standards, basically the principle is we are using the 5th edition. We have the standards as well as the assessment tool, and we have incorporated one set of all those standards requirement into one set of documents to facilitate the hospitals as well as the surveyors in the survey process. The evidence of compliance is also there, and this actually makes life much easier. So you can actually now prepare exactly what's required for the survey, during the survey, what is important for the whole day-to-day process. And what are the changes? We have actually reviewed the 5th edition, add additional core criteria have been identified in some of the services. Additional special requirements have been added. Cluster service standards for MOH hospitals have also been addressed for standard 1 for the lead hospitals and in standard 9 for the non-lead hospitals. So those are additional requirements specifically for MOH hospitals. Then we have also introduced 8 new service standards in this 6th edition. So we have got now a total of 53 sets of standards. Now we have also incorporated the new ISPA standard requirement for standards development based on the 2019 5th edition of the IEEA standards requirement. We have also addressed the latest updated regulations and CPJs requirements by the various professional or clinical services. We have also adopted the patient safety goals under WHO, as well as the latest Malaysian Patient Safety Goals 2.0, which is going to be released on the 17th of September of 2021 on the World Patient Safety Day soon. So Ministry of Health is holding it. We wanted to have access, but they only gave us some of the goals that has been, so it's already there in standard 1 for all of us to address, but we hope to get that document so that all our clients will have access to those documents. I hope it will be made available in the MOH website. So these are the standards. If you look, all the standards in white are the 5th edition, similar to the 5th edition, but it has been refined, updated, and some additional requirements have been added on. Then we have got standard 8, 9, 10. These are all still almost similar, but updated and refined. Now you can see that we have got 9G, the ones in yellow are all the new services that have been introduced. So we have got 9G, clinical services, surgical related services for ophthalmology. So this is very specific now for ophthalmology services. 9H for otorhinolaryngology, very specific. 9I is for psychiatry services, and 9J is for orthopedic services. Now the others, 10, 11, 12 is the same. Now under 12, ambulatory care, we have introduced ambulatory care services specific for endoscopic services. We have also developed ambulatory care services for ophthalmology daycare services. So we have got quite a number of standalone. This is applicable for standalone ophthalmology ambulatory care services, whether in the private or in the public sectors. Then we have got ICU 13, the critical care, and then we have got the 13A SCN, 13B is the labor delivery, and we have actually reviewed the chronic dialysis treatment standards. Now we have got the 3rd edition, which is part of the 6th edition standards as well. So that's already new. Then we have got, it has been reviewed, and we have put it inside the hospital standards because some of the services are within the hospital service, some are standalone, and the same set of standards is applicable for an hospital-based or standalone services. Then standard 14, radiology, 15, 16, 17, then comes all the allied health services, okay? Until 17J, we have got the clinical pathology, psychology services. I think not all hospitals have this, but generally the big state hospitals have got all these allied health services. In the private hospitals, generally they may have got until optometric services. Now then 18, we have got the pharmacy services, 19, central sterilizing supply, housekeeping, linen, food, forensic, mortuary. Standards for general application is 24, where we do not have standards. Generally, we can use standard 24. Now, then we have got a medical assistant. These last 3 sets of standards, including the new one, standard 27, disease, organ and tissue donation and promotion basically are applicable only for public hospitals. So medical assistant and standards for clinical research, because all the state hospitals have got these clinical research centers, as well as the organ and tissue donation promotion centers in all the state hospitals. They have just introduced this year. So that's where the standards have been addressed so that they can subscribe to it. Now, this is the format of the 6th edition as well, the same as the 5th edition, no change, except the contents have changed. So now I'll proceed to the rating scale, similar rating system as the 5th edition, but with more refined accreditation status as well as decision-making process. So we still continue maintaining the scale, 1 to 4 scale, 4 being excellent achievement, 3 being good achievement, 2 being fair achievement, where if you only achieve within 40 to 59% is 2, and that's not good enough. You must achieve more than 60%. So this is where all hospitals, if you want to get yourself accredited, you must make sure when you submit your self-assessment questionnaires, you must achieve a rating of minimum of 3, nothing less. If you put a 2 in your self-assessment, you will not be able to access into our my electronic e-health system. You will be rejected. And that when that happens, it means you are not ready to be surveyed, to be assessed. So you must achieve more than 60% compliance to the said criteria. Okay, so that's how the system has actually stopped you. If you have not really ready, you will not be able to access the system. So you cannot send in your self-assessment, and we will not be wasting your time as well, our time. So keep on improving until you have reached to that level, more than 60% compliance, then you can request to be accredited. Now, 1 is anything below 39%. So the methodology of assessment also not so much changed, but it's important that every service will be assessed. Now, one of the things that I would like to stress again and again, especially because we have got a dual system, we have got a public and private. Now, for public hospitals, generally, we have no concern because they don't have a license. They are given a framework of what are the services that needs to be delivered. They are directed by the Ministry of Health. But however, for the private hospitals, every 2 years, we are required to have a license. And we based on our accreditation surveys based on what services that have been approved in your license. So that is very important. So over the years, we have experienced quite a number of hospitals, private hospitals, who have been delivering services that do not actually have not been stated in the license. So this is something that needs to be addressed. Yes, we are not supposed to report. We are not a whistleblower. We have agreed that whatever that we see, observe in your facility will remain confidential, but you are accountable to your service. Please make sure that you deliver legal service. We do not want you to end up in court when one of your patients say that you're providing illegal services. And I hope the PIC here takes more cognizance of what are the services delivered and not just leave it to the administrative people to deliver services. So I hope you all should address your standard 1 governance, leadership, and direction appropriately. And I think more focus will be given to that standards to ensure that services provided are legal, ethical services. So award accreditation status will be based on the overall achievement of each service standards. For a service standard to be awarded a rating of 4 or 3, all core criteria must achieve 3 or 4, minimum of 3, okay? However, core criteria with a rating of 2 may be acceptable if the criterion is moderate or low risk, as calculated by the risk matrix that is being provided. However, this is not at the level of the hospital. Hospitals must make sure when you submit, it is either a 4 or a 3, more than 60%. In the event the surveyor's assessment decides that you have not achieved that 60% level, they downgrade your rating from 4, 3 to 2 or 1, then they are required, the surveyors are required to do a risk assessment. And this is where the issue comes in. So if your risk assessment is moderate or low, we may still accept it, but there are limitations to it. But if the risk is high or critical, the whole service performance may be affected, and that will also impact. And if the impact on staff and patient safety is also critical, then you may not be able to get your full 4-year accreditation status. So this is where we have actually much more further refinement of our requirements. Previously, we have given a 20% rebate of all the core criteria, but this time around for the 6th edition is only a 10% rebate. So if you have got 10 core criteria in one standard, it means to say that out of the 10 core criteria, only 1 core criteria is allowed to have a rating of 2, but with a risk assessment of low or moderate. If you have more than that, then the whole service may not get a 3. Okay, so it may be a 2. Once you get a 2 with a risk of critical or high, then you may not get your full 4-year accreditation status. Similarly, for the non-core criteria, we also give you a rebate of only 10%. Say, for example, you have got 20 non-core, you're only allowed 2 of the non-core criteria to have a rating of 2 with a risk assessment of low or moderate. Okay. So all the risk assessment will be conducted by the surveyors using the risk matrix that we have trained them. Okay, so that will not be part of your requirement at the hospital level. Now, overall performance of each standard is based on the impact on patient and staff safety. Also note that criteria that are not applicable shall not be counted in the total tally of results for the specific standards. However, we appreciate that if it is not applicable, you provide some explanation of why it is not applicable in the standards under the facility comments so that we can understand your organization better. So this is the risk assessment. This has been standard, which I've been using, we have been using over the years, and this is also being used by ISQA. So I don't think I would like to talk about this. This is more for the surveyors to handle. So a non-applicable criteria, there are in certain situations, depending on the type of facility, the criteria and service standards may not be applicable to the facility. So if it's acceptable, we accept as long as you make sure that it is truly non-acceptable. Any criteria that's not applicable should be noted in the self-assessment under the facility comments, and where the survey teams finds evidence that the criterion is applicable, you may say non-applicable, but if the surveyor feels that it is applicable, they will then assess it and provide it with a rating. So make sure you can actually engage with us at that point when you are going to conducting your self-assessment. You can request and ask us, get our advice to see whether that is applicable or not. So please take that opportunity to engage with us and get our support to enable you to move forward smoothly. Now, how do we award the accreditation? This is how we award the 4-year accreditation status. We have actually grouped up our services into 3 groups. The first 7 set of standards is group 1. This is a hospital-wide service standards. And it's important to note that this runs through from the front gate to the back gate. So all services are involved with these services, and these services is important. And we have mentioned that they must achieve an overall rating of 3. Okay. However, we are actually at a point of discussion now, especially with the challenge of COVID-19. Prevention and control of infection is an important set of standards at this current era. We will be discussing it soon to see whether we can actually make sure or make it a mandatory requirement that it must achieve, hospitals must achieve a rating of 3 minimum to get a full accreditation, no 2. So the exception will be, you got standard 1, 2, 3, 4, 6, and 7. In any of these 6, 1 services can achieve a rate of 2, but not prevention and control of infection. So we will share with you whether that decision will be final in the next training program. Okay, I know there are challenges, but I think there are ways and means to overcome these challenges, which we will further discuss in the on the 22nd and 23rd of September training program. Then, as I mentioned earlier, 10% of this service is allowed, so only 1 service, except for most probably not for infection control. Similarly, for the group 2 services, these are the group 2 services that all the clinical related services. Okay, so they must achieve 3 or 4, except we are giving a rebate of 10% instead of previously 20%. So now if you have got 20 services in that group, clinical services, so only two services are allowed to get a rating of 2 with a low or moderate risk. Similarly, for group 3, all the other services, the allied health plus the not the support services, you must achieve a rating of 3 or 4, but we still give you the 10%. So if you have got 20 services, it means in the group 3, so it means to say you can have 2 of those services with a low risk of low risk or moderate risk. Then you can get your full 4-year status. So it's a bit stringent now, but we have gone through the results from the 5th edition that we have experienced for the last 4 years. We see there is about 70 to 80% of the hospitals have been able to manage to get this sort of performance. And that's the reason why we are putting in stringent measures now to ensure that that decision is moving forward, and we are getting towards providing better and better care to to our patients. So that's where continuous improvement takes place in the whole program. So decision for awarding accreditation status takes into consideration the overall impact of hospital service that they assures to for patient safety as well as staff safety, and recommended score from the surveying team, counselors, as well as the aggregated score from surveying team as well as the counselors aggregated score. So that will decide whether you get a 4 years, 1 year or non-accreditation status. Now, if you get a 4-year status, we have actually also decided to give you an excellent achievement if all your service standards achieve a rating of 4, no score of 2 in any of the services. Otherwise, you'll get a good achievement. Okay, I think almost for the last 5th edition, so far we have not got any, we got 1 or 2 almost getting an excellent achievement, but all have got only good achievement so far. So we keep that, and hopefully hospitals will strive to get that excellent achievement in the 6th edition standards. So 1 year, if you don't fulfill the requirement for 5.1, and your areas for improvement and recommendations can be rectified within the next 12 months period. So that will ensure you to come back for a focus survey within the next 12 months period. So if you don't comply with 5.1 and your areas for improvement and recommendations requires more than 12 months, then we will not be able to give you any accreditation status. So a non-accreditation status will be provided. It is good over the years since we started we never had any hospitals that came for a survey that ends up with a non-accreditation status. And that's something good, because if we find your self-assessment is not up to the mark, generally we will advise you to actually go back, look at your standards again, and get a new date for your survey. We do not want to go to your hospitals and then assess you and give you a non-accreditation. Generally, if you submit your self-assessment on time, MSQH Secretariat can actually review and see whether you are able to move forward or we need to give you a new date. Okay, so I think that's where the enabling part of the MSQH contribution to your service. We do not want to give you a non-accreditation. So this is an educational process. Where possible, we are willing to provide you with the support to ensure that you move forward and achieve to the desired compliance rate. Now, once you get your 4 years, we have got this maintenance program. Every 12 months, you need to provide a compliance report. And at the 12 months, we also need you to provide a compliance report. We plan to actually provide a surprise surveillance, but this has not materialized. I think only the first few hospitals had that, but subsequently, we are running short of budgets to send additional surveyors, but we do continue to have the documentation review at the 24th month as well as the 36th month. So we hope the board may consider providing additional resources or increasing the fee slightly higher so that we can afford to send surveyors, 1 or 2 surveyors, 2 surveyors minimum for a day during the 24th month period to conduct this surprise surveillance survey. It's not actually surprise on the date, but surprise on which services we are going to verify or validate during the surprise surveillance survey. So you need to be ready. We will not inform you which services, but we will just randomly check based on the previous reports. And if you comply with that at that time, you will continue to maintain your 4-year accreditation status. Otherwise, we'll provide you with a report and recommendations for you to act further. And at the same time, every day we do monitor the performance of all accredited facilities. And also we actually provide feedback on adverse reports. We ask you to provide feedback and provide advice on what is necessary to be done. So hopefully you can also self-regulate and sustain your accreditation status. We do not want to see a roller coaster quality happening, which we experienced during the early years. So hopefully quality will be continuous effort. It's a journey for everyone, and we keep continuing to improve our processes and our outcome. With that, thank you very much for your attention. Back to you, Aiman.
Doctor, please stop share.
Yep.
Okay. Sorry, spotlight. Okay, thank you to Dr. Kadar for the sessions. It is important that to note that the significance of our accreditation program is an update for the standards additions is to ensure that continuous quality improvement so that we can uphold the patient and staff safety in our facility. So for further details of our 6th edition, we will more discuss in our September training. So make sure you can subscribe or register for the September training. Okay, thank you. So for any question, you can put in, if you are in FB and Facebook, you can put your question in the chat room in Facebook. If you are in Zoom, you can put your question in the chat box so that we can discuss after the sessions. Okay. Then we will proceed to, we invite Professor Dato Dr. Rahim bin Abdullah and followed by Ms. Noramiza to present their slides and also to continue the session. Thank you.
Miza will present first.
Oh, Cik Miza dulu. Okay. Cik Miza.
Okay, good morning. Can you hear me?
Ya, boleh.
Can you see the slide?
Yep.
All right. Okay, good morning, everyone. Basically today, I will actually just give you some briefing on the survey process and the administrative requirement for the 6th edition hospital accreditation program. Basically, what we introduced in the 6th edition is not much different from the 5th edition. It's just an improvement and refinement of the standard and process. Okay. Okay, this is our flow on the hospital accreditation program. If you can see here, everybody knows that MSQH is actually a voluntary process. So you need to request to MSQH officially the program that you want to proceed. For this one is the hospital. So it's a request to conduct for the first cycle hospital. Normally it's a training first lah. But for the subsequent cycle for second or third and onwards is actually either the updates on the standard for the program and followed by your preparation towards the program. So after this webinar, there will be the specific or details on the standards training in September, and that one we will further explain on the requirement of the standard and as well as the new edition. The new service standard introduced. Okay, so after the preparation on your standard interpretation, you need to do your self-evaluation on your side, and basically by around this time you should already know your preparedness towards the survey. So you can contact us again to book or to plan your survey date with us, and we will again look at our schedule and slot you in for your actual survey, right? This one, the surveyor identification is actually on our side, and we will contact you, or we will get back to you on the consensus of the surveyor's appointment. However, during the same time, all the document or assessment need to be submitted to MSQH in order to proceed with the survey. At the moment, there are three types of surveys that three methods of survey that we conducted. Either it is on site, virtual, or hybrid. Okay. I will explain on these two process, which is number one is the offsite documentation review, and another one is the survey. Currently, from the last year, we already conducted the offsite documentation review due to the pandemic COVID-19, where we actually request more evidence or more document in order for our surveyors to do your survey earlier, before your actual survey. Okay. The document that we requested earlier is basically the document that will be surveyed by the surveyor during the on-site survey. But we request it early is for them to do their assessment, or for them to take some notes to ensure this area can be further evaluated or verified during the actual survey. Either it is an on-site survey, or it is a virtual survey, or hybrid survey. The document requested are all the same. These are all the document that requested. Yeah, the pre-survey assessment, which is the which is the questionnaire. Currently, it is in EHAB. We will use the same. We will use the electronic version assessment. but the link nanti we will provide you later lah. Together with the assessment, the hospital profile, the departmental profile, policies and procedures, main statistic, indicator, list of consultant, and the additional information that we requested now is the evidence of compliance. What is the evidence of compliance? The evidence of compliance is actually the evidence that we already explained in the standard, in the survey assessment tool, where you can see what are the evidence of compliance we request for each criteria. So each criteria need to be included with this evidence of compliance lah. So the document that you submitted to us via this e-document, which will be informed later, is actually the same document that the surveyors will see during the survey. So if they are satisfied with the document you provided, then there will no issues when they're coming for your survey. Okay, so make sure that you submitted the correct and complete document to our surveyors. And if possible, the document to be submitted 6 weeks before the survey to ensure that our surveyors have ample time to review your document. Okay. Next one is the on-site survey. The survey. As I mentioned just now, there are 3 types of survey that we are conducting. The on-site survey is actually our main option. For hospital that undergoing first cycle survey, this is compulsory. But for the subsequent cycle, for the second or third, if the if the situation is okay for us to travel, we will do the on-site survey. However, we will opt for the other virtual survey or hybrid survey if the condition is not suitable at that time. So during this on-site survey, we will minimize contact time and need to comply with the MKM guidelines lah, the current at that time. Okay. Next is the virtual survey. The full virtual survey is actually, as I mentioned just now, it's suitable for the second cycle onward survey, also for the hospital focus survey. If possible, we will do the on-site. If not possible, we'll do the full virtual. And other facilities which is maybe the medical clinic, dental clinic, and so forth. And it will be conducted via Zoom. So we'll create a multiple breakout room specific to the service standard. So each service standard will follow by the specific surveyor, and your hospital staff will be in the same virtual breakout room. The survey conducted via, the interview will be conducted online as face-to-face online, as well as the virtual visit. Okay. However, for this virtual survey, there will be an on-site visit within the 12 months after the survey, within the 12 months. So the function or the purpose of this on-site visit within 12 months is to observe all the major issues, especially on the facility, because during the virtual, we understand that there's not full view of the hospital that we can observe, and not all the team of the surveys will be involved, only a few of them. So the philosophy during this virtual survey, actually we want to enhance on the governance, trust, empowerment of the hospital, the PIC or CEO responsibility and accountability, as well as the self-assessment, how you conduct your own self-assessment. Okay. The system required for your virtual survey and hybrid survey is basically you need a good PC or laptop, notebook with latest version of Zoom, as we want to optimize the features, the full features of the Zoom, and good internet connection, either it's wired or wireless. good speaker and microphone, as well as the webcam or HD webcam. The handphone also used in during the survey. So this requirement will also be details during our training with the hospital and team. Next is actually the hybrid survey. Hybrid survey is actually part of the team will be on site and part of the team will be virtual. And those who are on virtual, the same applied as virtual survey just now. We will use also the Zoom and as well the multiple breakout room. But the on-site team, they will actually to observe on the physical structure and healthcare facilities, as well as to verify the actual practice on site, compliance with policies, clinical practice, and as well as to double confirm or check what are the virtual team found during their virtual visit or virtual interview. And this hybrid survey is actually suitable for hospital survey and other facility survey lah, and depends on the situation at that time whether we can do it as full on-site, full hybrid, or full virtual, or as combination of these two. All right, I think that's all from my presentation. The next slide will be presented by Prof. Dr. Rahim. Okay, Dato, I pass to you, Dato.
Thank you, Miza. Thank you very much, Miza. Yeah,
Right.
I will just add a little bit on the survey with regard to the virtual surveys and the hybrid. Just to add on to what Miza has mentioned, is the information with regard to what is the acceptable by ISQA, IEEA, the International External Evaluation Assessment of it by ISQA, for the standards that they recommend that the survey should include around 30 to 40% on-site survey. The nature of clinical services, as well as the facility, the engineering services and the biomedical system, the requirement of physical verification, validation of the evidence of compliance of the standards, criteria have to be there. So that's why we try as much as possible not to do virtual survey, but for focus survey, we have that option of doing a full virtual survey depending on what are the things that we need to see, all right, for focus survey. So we have done a focus survey fully virtual, and for those that is appropriate, right, we can do full virtual. But for full surveys, whether first cycle or repeated cycles, re-accreditation, we try to either do the full virtual with the mandatory within 12 months surveillance on it and verification survey, or we do the hybrid where we do it on go. This is if the SOP, as mentioned by allows, as mentioned by Miza just now, right? Okay. All right. All right. The virtual survey, as you know, the limitations of the virtual technologies, the tools and technology that's available, it's not the same as having our five senses, audio, visual, the smell. You know, as the last 20 years, or the smell is one of my tool when I go to survey hospitals. Nice smell in the kitchen, you know, that smelly rubbish or garbage, I call areas. Those are telltales of problems in the structure and process, meeting the standards of what we have set in terms of compliance. Okay, so even in terms of visual, your visual field is going to be limited, right? Okay, and you do not have what you call this focus, and as well as the what you call looking sideways and so forth. This is different when you do when you are physically there on site, right? Okay. Even of course the as I said just now, ISQA, IEA accept virtual surveys, right? Provided we follow up as we have planned. Okay, we follow up either on site, whether within 12 months. Okay, all right. Okay. All right. Somebody asked me to start my video. No? No. Okay. I'm okay already. Yeah? All right.
Okay.
All right. Okay. Okay. The other thing I wanted to just tell you all is that the survey program that we have is we call the accreditation program that we have is basically hoping for hospitals to achieve the accreditation excellence, right? Mentioned by Dr. Kadar just now. Particularly if you're going to host centers of excellence in your hospitals, right? Or standalone centers of excellence. And you may want to fulfill the ratings to the maximum of 4, right? Hosting. Of course, being centers of excellence is another what we call achievement above accreditation excellence, right? We are hoping that many hospitals are going to focus on that in the near future and in the future, and come up with what you call recognized certified center of excellence, as that we can plan on. All right. I just like to remind all of you is the most important thing that we want to look and see in the hospitals or any healthcare facility is whether they have an improvement process, they have an improvement culture in their facility, right? Whether in terms of quality, enhancing quality, or and also in terms of lowering risk, which means increasing the safety aspect in the facility. And the other aspect that we want to see is also the patient-centered care and how you respond to patient family rights. That's one of the important services there. And patient-centered care is going to be something that we're going to pursue further in the 6th edition. For example, you already gone there, but we want to go further as required by ISQA new standards. Particularly like for example, being wellness focused, having your patient, your pain, what we call assessment and so forth, and how you respond to pain. That's about being well, whether in the hospital as well as upon discharge, and how that is maintained. For example, the informed person, informed patient, informed family, how you're going to assist them, facilitate self-help, assuring and continuous and seamless care, tailoring of customizing your services to individuals or groups of patients, right? We have done this, but we want to see how to go further as we move towards the future, right? There are what we call the frontier is continually moving, right? Okay. The other thing that we are going to focus more is on the e-document, as we have learned from our pandemic, is to have a what we call the hospitals or the healthcare facility strategize your information system to align with our standards, with our criteria, because I see some hospitals have done that, making a strategic alignment with the accreditation program and the standards and the criteria, so that it's easy for them to store, retrieve, trace, all this information, right, and knowledge for your own benefit, as well as when the surveyors request for it, or when surveyors go through the survey process. So that's important in terms of alignment of that the information system that you have. Okay. Okay. The other thing is also we want in the 6th edition is to encourage more hospitals or facilities to have their own surveyors, because we want to embark on the empowerment phase, right? So that a lot of self assessment by a facility will be done very well, right? Very assured, because they are surveyor or they are surveyor trained, right? So we can trust them more in terms of how they conduct that self assessment, and of course in terms of how we can empower many of the what we call verification of the evidence of compliance, so that we the accreditation survey process in the future will try to do less, and not because we want to do less. It's also because we want to be more efficient, right? Be more effective as well as be more efficient in the future. To ensure that the rising costs, I mean, healthcare cost is rising. Even the survey cost is also rising. Buying the technologies and system and so forth. All this. So we do not want to increase the fees unnecessarily if we can control, right, the cost by other means, right? So not necessarily or unnecessarily increasing the fee, right? Okay. For example, a small hospital with 25 services, they have at least one surveyor. Up to 35 may have another surveyor. Up to 45 can have 3 surveyors. They don't have to be surveyor himself, but they are surveyor trained, right? Surveyor trained at least the minimum to ensure the empowerment phase gets started in the 6th edition, right, and onwards. All right. Okay. One other thing that people always ask, why the hospital in Sabah, Sarawak, there in the rural, not like the hospital in KL, especially the private hospital, all the what you call first class facility and so forth. They can pass accreditation. All right. I think the accreditation is about resource setting. All right. Okay. You have to match your level, the scope of your care, of services that you want to do, and the level of care that you want to provide, right, to deliver. All right. Whether it's outpatient or just community outpatient, or whether it's inpatient, general inpatient, or specialist inpatient, and the other level is critical care. All those things require different level of resources. So in order to get yourself providing best practice for that resource setting or resource level, then you have to adjust all these variables to ensure that at the end of the day, quality service is provided, right? And it's safe. Safe for the patient as well as safe for the healthcare workers as well. Right. All right. Okay. We will do that in the next month training in more detail. Right. Okay. Okay. The thing related to that part on resource, if you see the gap that you have in your standalone facility or in the well-resourced hospital, there are still gaps. The gap analysis is very important, that you need to be able to identify, right, where the gaps are, where the risks are, and create a plan how to protect that, right? Risk protection, as you would ever call it, right? And add the plan the extra precaution that is necessary to if you don't, then you have to what we call temporarily stop the service, right, until the resource level is up. There are lots of things that you can do by process technology, as well as other tools and technologies that are available to actually overcome those gaps, right? It's not necessary to make a new hospital or make a new building and so forth, right? Okay. and you have to go further in having a monitoring and surveillance plan and how you detect those risks if it comes. They call it incidents or near misses and so forth. Incident reporting is very important, right? Okay. If you still want to continue that service, the specific process or service that you want to do. All right. And if it happens, you must have a response plan and a recovery plan. All right. This is additional requirement by ISCOR IEA that you need to have in the 6th edition, right? The response plan and inclusive of the recovery plan. So, I know you're saying that you have that in OD. Yes, that's very good. But we want to see that specifically when we do survey, not just for that disaster plan, they call it, or the contingency plan for the engineering, but it has to go also looking at clinical risk, all right, clinical risk profiling. All right, for the start, just look at a few major ones, important ones. All right, you're not, as I said, this is a journey. Our accreditation program is a journey, and we want to keep moving forward. All right, catching up with the developed countries. I say catching up, and not see them going further and further. I think that is important word, catching up. All right. And ensure that at the end of the day, for all what is worth, that is worth ensure patient safety while providing quality outcomes, right? Through best practices, right? Through best practices, which is current, For accreditation, we are not looking for cutting edge or advanced technologies and so forth. As long as it's current, not out of date structures and processes. Okay, but that is not acceptable. All right. All right. So I go to my slide. It's just prepared by Miza. This after the MCO, we hopefully we hope to progress to be more sustainable and more resilient in a way, all right, to ensure that our accreditation program, our survey processes will keep moving despite the pandemic or any other inverted comma. I hope hopefully doesn't about disasters. Hopefully doesn't occur, right? Is to pursue the full surveys and first cycles as on-site and also as hybrid. Okay, as hybrid. All right. Where is mutually agreeable, we can do the those two options. All right, it's about mutual agreement from both sides. We listen to the facility, the hospital, the healthcare facility, and hopefully the facility will also see our limitation as a non-governmental, non-profit organization, as mentioned by Dr. Kadar. We don't make profit. Whatever profit we have, we channel back into the system, our tools, our technologies, and so forth. Right? Okay. That we need to improve the survey, the acquisition program, and the survey process, and other activities related to MSQH, advocating and being activists in quality improvement and patient safety, at least in our country. Okay, all right. As I mentioned just now, a focus service, we can do full virtual where appropriate, where we don't actually unable to verify through pictures or images or audio or any videos. All right. Okay. One of the things we can do is actually send a local surveyor. But if you have what you call a surveyor in that hospital, all right, then it's easy to get the surveyor who's trained to actually do an assessment. As professionals, we trust each other. Therefore, we empower each other. All right. It's a journey to gain that trust and then gain the empowerment. All right. But it requires commitment from everyone, right? Particularly our top management, our executive, and so forth. But also in terms of being open, the openness and transparency must be there. That's what peer review is about, where we have each other. So to touch on Dr. Kadar's part on people no one has actually got what we call a failed accreditation process survey. All right, but there are several. There's some who gets one. I always advise the CEO, the PICs, and the staff. Don't be shy. If you are professional, you're not going to be shy or feel ashamed or feel down, because we got 1 year. All right. It is what I call a process. This is an opportunity. Don't be afraid to get 1 year. If you get 1 year, then you have another opportunity to improve yourself. That's what we want, the culture that we want, right? To be able to get 5, 6, 7, 8 surveyors to come in, experts to come in to share with you their experience, their best practices, whether they are own or they learn from other hospitals or other healthcare facilities. I think that is very, very invaluable, right? You can even cost it, right? All right, as compared to how much it will cost, all right, to just do a focus survey. The focus survey is minimum. We've been charging only 10,000 ringgit just to come to send 2 surveyors to do the focus survey. But in return, you get our two experts to come in and help to evaluate, educate you, enable you as well. All right. So that is to me very little as compared to what they can knowledge and expertise that they can share with the hospital or standalone facility.
We need to 12 o'clock.
I'm finishing, yeah, sorry. Okay, so it is important to think that way. It's about the mindset, it's about the thinking, it's about the culture. Hopefully, once we do that, then the trust and empowerment will be there. Right? If we trust each other and we produce good achievement in our accreditation program, I think it will be recognized by people outside our program, and then recognized by our clients, our customers, even by other sectors in the industry, right? Like industry, and of course outside the healthcare sector as well. All right. Okay. The last slide is about those facilities that are prepared for re-accreditation or even as a first cycle. That's prepared with the 5th accreditation standards. You still can go through the survey, right? Because at MCO, we are going to extend the deadline to 30th June next year. So, all right, as I said, so you still can proceed within the 5th accreditation standards survey. All right, those who are trained in 2020, right, especially, right? This year we haven't done any training, and the survey has been postponed in 2020 and this year, all right? And we have given up to a maximum of 1 year extension. We can't go further than the 1 year extension. And there are a few who have 4th accreditation standards, right? However, if you feel that you can go and proceed to do the new 6th edition, we will of course recommend that instead. But nevertheless, you need at least 4 to 6 months of implementation of the 6th edition standards and the reports to show it, right? The evidence of compliance of the new standards. Okay, all right. So thank you very much, everyone, for listening, joining us for this introductory briefing on the 6th edition. Hopefully, many of you will join us, right? Especially the main players, the champions and so forth, particularly as many as possible. All right. Join us on the 22nd and 23rd of September. All right. For those hospitals or facility who wants what you call specific training like that we have done before, that this is by request that we go or just entertain your facility or train your facility in terms of package 1 and package 2 that we have done before. Package 2 is actually the gap analysis training. All right, as I mentioned just now a little bit. Right. So thank you very much. Right.
Thank you. Yeah, thank you, Professor Dato Abdul Rahim and Ms. Noramiza for the explanation, especially on the virtual and hybrid survey. Just to inform you to our current pandemic situation, I hope that we will try to our best to carry out our accreditation program to ensure the patient and quality of the patient safety and quality improvement process is carried on. MSQH will guide accordingly due to the virtual and hybrid survey. So please do not worry. We will accommodate you accordingly when times come. However, full on-site is the first choice, but depends on our current situation. I hope our situation will become better so we can move forward together. So I will proceed with Q&A session. So we have you can ask question in chat box. Please put your question in the chat box and also the FB chat so we can go. So these are a few questions. We have Ms. Noramiza here, Dato here, and also Dr. Kadar. Dr. Kadar ada ke? Okay, question. Sekejap saya share question tu nanti. Nampak ke question? Can you see the slides? Boleh ya? Dato' nampak saya, Dato'?
Yes, I have to take my specs.
Okay, nampak tak? Okay, so for the first question, yang ni Cik Miza ke Dato' boleh jawab. So for the first question, if there is only one ophthalmology, does it need to be surveyed as less than one specialist is not considered as service? Boleh, so Dato' ke siapa boleh jawab?
Okay, I'll take that. Is that okay, Dr. Rahim?
You're going to answer that?
Yeah, okay. Now, the reason why we have got additional clinical services in service standards in the new 6th edition is because one of the requirements under the Private Healthcare Act and Regulation 2006 is that it says that where you have 2 or more consultants in a service, you're supposed to establish a department. So whereby when we say that 2 or more, then you're supposed to have your own set of standards, SOPs, your own facilities, your own staffing, your own requirements, as well as measuring the performance of your service. So that's the reason why we have encouraged that, we have developed that and put that in place in the 6th edition. And it also will provide you with a good marketing strategy, especially for the private hospitals, that you are recognized as a specific discipline, not just as a composite of surgical related disciplines, a composite of medical related. So here you have got the opportunity, but now having one ophthalmology may not be necessary, but if you think you're capable of doing it, we have no qualms of providing you with that certification if you can afford to do it. But our requirement is that if you have 2, you should have your own service.
Department.
Yeah.
Okay, can I add that to that?
Yeah, go ahead.
A department and a service is 2 different things.
Yeah.
Right. If you have 2, then you need to have a department or a unit, whatever we want to call it. A unit if it's a small one, department if it's a large one. For one ophthalmology, you can have a service. All right. But the way we're going to look at it is that how much workload do you have? All right, you can share the wards and the staff, all right, but there are requirements when you share the ward and the staff with regard to adequacy of the resources. For example, if you have ophthalmology, all right, and you share a ward with a surgical ward, for example, okay, and then the staff, right, one of the important things is the staff, whether the staff has got post-basic, for example, the staff nurse and the nurses, all right. The very least privilege to actually take care of ophthalmology patient in terms of that. This is basically the same thing with the other specialties or subspecialties. Okay, so those requirements, even though you share facility, the ward and the staff, all right, but the requirement of the standard is still there. So a service, even with one specialist, if the workload is there, I think there is no reason why that service should not be surveyed. As you may, the standard is about the services. We don't say it's a department, but the department is basically what the Kadar described as having your own. Most of your own resources and facility and stuff. Right. Okay. All right. Is that clear? Okay. The next one. Who is monitoring if a hospital is operating the service illegally?
Illegally.
All right. All right. This this is a legal, which is the CCAP. All right. As far as we are concerned, we have no reason or no obligation to report to CCAP, the enforcement on the legal requirement. Our job is to identify it and discuss it with the CEO or the PIC or the hospital director if it's a public hospital, and to just tell them that this our observation, our finding, and that something has got to be done with it. We don't want the hospital to be caught whether by CCAP or post incident, in the sense of post incident, like the incident of the plastic surgeon giving what you call providing services, but not licensed for some other services on top of that, like general anesthesia or so forth. Right. Okay. So we, as a professional, we will do that. All right, for all the facilities that comes, our members, not just accredited, but they are our members, even they are not yet accredited. We will advise them so. Yeah, that way. All right. So the other part on patient, when you mentioned about patient, won't know till too late. This is where the movement initiated by WHO and is taken by Ministry of Health, and has requested MSQH to what you call be active in the patient safety movement. All right. So the patient safety movement would be what you call advocating and informing by virtue they are a network of patients, who wants to be in the network to be able to be well informed with regard to all of this. All right. Okay. All right. In general, the next question, based on MSQH records, how many % of hospitals were given with 1 year accreditation? And we can share the reason. Dr. Kadar, you can answer that.
Well, I think this one, through our experience in the last 20 years, about less than 10% of hospitals that come forward for survey gets a 1 year accreditation status. And I think majority of them are due to standard 2 and standard 3, okay, occasionally. And I think majority of these hospitals from the, sad to say, is from the public sectors, because majority of them are more than 50 years old. You know, some of them are running short of resources, and things have not been addressed adequately. And of late, with the ventilation system, with the air conditioning system, I think having split units, all these are issues that have been there for quite a long time. And I think based on our stringent requirement of standard 2 and standard 3, some of these hospitals do have problems to comply substantially or to achieve the 60% level. So that's where they actually do get a 1 year accreditation status. But generally, through our experience, majority of the private hospitals, in fact, I think it's 96-97% of private hospitals that comes in for surveys, accreditation surveys, get a straight 4 years. They have better resources, you know, they can mobilize people, especially if they are a chain of hospitals. They do mobilize staff, you know, from one hospital to another to support, and then they share the resources, you know, especially on policies and, you know, procedures. They do training programs together. They provide internal auditors, you know, to go around to hospitals, and that is a strength. That's the sort of empowerment that we're actually looking for. In fact, the Ministry of Health hospitals did the same during the early years, but apparently after some time it fades down and things don't seem to work out, especially now with the COVID. I think their hands are full.
Yeah. So to add to that, basically in the early years we had what we call issues a lot with the facilities and biomedical systems and the environment. I think that has improved, right? But the public hospitals, or the aging public hospitals, particularly in the rural, remote areas, I think if they've been well maintained, then they're okay. But if they're not well maintained, then that issue will come back to haunt them, in a sense. All right. The other areas is looking at clinical services. We are very particular about clinical services. All right, and particularly if the risk is rated as high or critical risk, then we won't hesitate to lower the rate, the offer, the award to 1 year. But as Dr. Kadar mentioned just now, in terms of overall, you still have what you call buffer to still achieve what you call 4 years, if they're within that range, the buffer with regard to number of services that can be allowed to have fail the survey. Yeah. And then next.
Okay, next. Okay.
Okay.
Can you expand further on cluster services?
Okay, the cluster services has been initiated by Ministry of Health, since 2013. I think 2013. At least there was a time when I was involved. I was called to help them to come with cluster services. Basically, cluster services is not basically in terms of the business goals of the cluster, which is being more efficient, but also, but particularly, I'm more concerned on the providing of better care, particularly in terms of providing specialist care closer to home or closer to where the non-specialist hospitals are. So the cluster services are structured in such a way that the smaller hospitals, the non-specialist hospitals, are grouped together with a specialist hospital, considered as what you call the principal or the main hospital, right? And the main hospital becomes the mentor. It's not just mentoring, but also in terms of obligation and responsibility to ensure that the services provided, not just the services, but also the facility provided by the non-specialist hospitals, the smaller hospitals, reach a certain standard. As you know, basically in the public side, the smaller hospitals there, they have inexperienced staff there, whether they are the director or even the hierarchy of healthcare professionals there. All right. The goal is to ensure that the patient, all right, receive the best possible care, all right, so that when they arrive at the specialist hospital, they are in the best possible shape. All right. Okay. Secondly, is to ensure that we don't unnecessarily refer too many patients and cause overload of staying inpatient in the specialist hospital, which is what we see, and therefore stress the specialist hospital with regard to the needs for beds, the need for beds, right? Okay, so and of course the other one is you can send back patient to recuperate in the non-specialist hospital for maintenance antibiotic, for example, or dressing in the smaller hospital. Okay, so roughly that is so in our standards for non-specialist hospital standard services there. We have included those services, and also in the governance part. So if they are within this cluster with the 3 or 4 hospitals, we're going to ensure that their structures, their processes are consistent, all right, and meets those goals, all right. Okay, I think that's otherwise I will have to give a 2-hour lecture if I go for that. Right.
Okay,
Alright.
basically it's only for cluster services, is only for public hospital, not applicable for private sector, kan Dato?
Well, I mean, it is possible, if the big operation with many hospitals, they want to cluster, all right, in their own approach, their own method. They can have that. But the essence is about continuity of care, seamless care. That's the essence, all right, and that the best practices, where possible, are being delivered from the first contact. Yeah. Okay. Okay. Next one.
So if the physical survey done within 12 months, will the cert be given after the virtual survey?
Yes, we will give the after the virtual survey, the full virtual survey. All right. Provided they meet the all the what we call compliance of the evidence have been verified. So within the 12 months on-site survey, right, a physical survey, on-site survey, is to upgrade or downgrade some of the ratings of the evidence. And if we find that we can upgrade, then we will upgrade from 3 to 4, for example. All right. Okay. To have a 3, we will be focusing on those rating of 3 on terms of the criteria, so that when the surveyor goes there, they will be focusing on those criteria that are rated as 3. All right, and then they will look at it and see whether they can upgrade it to 4. All right, if they see that it doesn't meet what is in terms of what is documented, right? What is clarified during the interview, during the virtual, all right. The surveyor may downgrade that to a 2. And if that ratings, a lot of ratings in the service have been downgraded, then that service may or may not, right, be downgraded in terms of their rating form. Say, for example, from a 4 to a 3, right? And it's not impossible that the rating may be a 3 to a 2. But the important thing is about openness and transparency. If the virtual survey can achieve that, then there will be what we call a few situations where we have to downgrade, right? Okay.
Okay, thank you, Dato. I think we cannot accept more questions. We have a lot of questions to answer. For more information, you can ask during our
we can reply that. Can we reply that on our website?
Macam mana reply on website? Mungkin tanya IT.
By the question.
Macam mana Kak Lana for one?
So those that we can reply, we will reply. For those that we want to elaborate further in September, all right, we will do that in September, because a lot of the details will be will be in September 22nd and 23rd.
But Dr. Rahim,
Yeah.
perhaps some of these questions we can actually address that in the next training, 22nd and 23. We'll take note of it, and where we can, we will try to help out. Otherwise, if the individual person needs to know earlier, you can actually call us at the, contact us, and we can help you out with the answers.
Okay. Tapi yang ni doktor dengan Dato nak tengok dulu kan yang mana yang boleh jawab lagi. Saya bagi masa.
I think it's already, I don't know, but you promised them until 12 noon.
Yeah, I think in another few minutes. Let me have a look. Just
Yang mana?
all right.
Okay.
Okay.
Yang bawah rating Prof. Dr. Kadar referring to 6 editions. Standard 26 is Accreditation. Yang ni doktor nak jawab ke?
I think this is, other
Okay.
Kadar.
Yeah, 26 and 27 actually is basically for public hospitals. These have been requested by the various people concerned with the CRCs as well as the organ donation. They said they have got centers in the state hospitals that are functioning. So they actually collaborated with us to set that standard so that the services at those hospitals can also subscribe to the accreditation standard and be subjected to the accreditation process. I think that's a request. That's what it came in, and it is there. If the service is there, then, and if the hospitals is going for accreditation, they should be part of the system.
Okay, so
Right. The next one, the clinical services. The clinical services, if you do not have your own specific standard service standard, then you will fall back onto your general standard. For example, neurosurgery will fall back to under surgical services.
9B, yeah.
Yeah. All right. For medical services. So and the appropriate what you call adjustment will be done by the surveyors in terms of the discipline or the subspecialty. We are progressing to have more and more subspecialties into the services as we move along to develop more and more standards. Okay. Next one, Ahmad.
Sekejap. Okay.
Okay.
During epidemic or pandemic, the situation is not ideal as the number of patients change, especially in COVID hospital. Can MSQH standard be relaxed? Datuk dengan Datuk.
Okay, standards are standards. It depends on that. For example, in a COVID hospital, a hospital who looks after COVID, and they have majority of the cases are actually inpatient COVID patient. You know? So we focus on the how they manage the inpatient. All right. Okay. This is for what we call like for example, Sungai Buloh. Sungai Buloh, if they are full COVID and they don't look after most of the services, then we advise them to delay the accreditation. Okay, the one that I mentioned was a non-specialist hospital. All right, what is important is how they ensure the management of the other patient. All right, because the other patient are equally important. Even if they don't, the patient comes in at the emergency, or how they redirect patient to the clinics, to the outpatient and so forth, and how that is being referred to the appropriate, how they have been triaged and assessed to be managed further. So we are flexible in terms of how we survey the hospital, right? In terms of what services they have on, and how the hospital have changed their strategy, the change management, how they manage that. That's how, so that they don't do anything that is not producing quality, and they don't do anything dangerous, high risk, unsafe situation. All right, so we still do that unless like a specialist hospital with such specialists, then we will recommend that they delay the survey. Yeah.
Okay, we must one question that will the MSQH accept a desktop drill due to pandemic?
Okay,
MCO.
this was asked earlier. All right. During the pandemic, we accept the desktop drills. All right. Okay. But you need to document it properly, right? Whether document in writing, the post-mortem of it, the findings, the report must be there lah, you know. And what have you analyzed in terms of the findings, and what the plan of action? All right, those things must be there. So we still do accept that, right? The desktop drills. Okay, even in terms of the life support training and so forth. All right. Okay. To ensure that the continuous what you call this updating. All right. Just because you do not have to recertify or say advanced life support, example, but there must be evidence of updates that have been given, whether through in-house lectures or through videos and so forth, But all that must be recorded, so as evidence and so forth. So that's the very least you can do. All right.
Okay.
All right.
Proceed. Yang ni saya rasa yang ni boleh jawab by apa? Boleh jawab by the first time survey pre-assessment visit ni saya rasa boleh jawab by email kan Dato'?
Okay. All right.
Jadi
So
kita boleh jawab by email.
All right.
Kita
Okay.
proceed to the next question.
Yeah. So only the
No, under the patients and family rights, this organ donation staff, I think the organ donation transplant service under MOH, initially actually before the COVID, they actually had a 3 days training. So that's more than actually 12, 20 hours. But I think recently due to pandemic, COVID-19, they've done it virtually, and it was done only for two days. So that's a short there, 16 hours. Never mind, we will talk back to them and see whether we can actually make some amendments. Thank you very much for that information.
Yeah, okay. Right.
Soalan bawah dia tu, public hospital already in the past hospital.
I think they can. All right. I don't say much, but I've been involved, in the planning, all right, and development of hospitals and so forth. It is, it's always something that is difficult in terms of in the public side. Where you, for example, in terms of nucleus hospital, everybody wants nucleus hospital at that time, and everybody used the templates. Because it is also a political, not just a business agreement, but also a political agreement between two countries and so forth, right? So there are lots of things, but at the end of the day, what you have, what resources you have, what facility you have to align it with what services you want to provide and what level of care you want to provide. And the goal is, all right, quality, care quality, and the safety of patient and the healthcare workers. I think that's generally right. If you can't do that, then if you take extra precaution, mitigate and so forth, and plan for improving that situation. Right, we want to see that and so forth. In the meantime, don't do anything that is high risk or critical risk, particularly to patient and healthcare workers. All right.
So next question.
People are allowed to have their own indicators. All right.
Okay. For
Okay.
this, I think indicated, yes, MSQH do identify which indicators you need to subscribe, but if you do have good justification why you want to readdress that indicators and come out with your own indicators, it's fine for us as long as it's being done consistently and you actually have got some objectives why you want to change those indicators and the reasons why and whether you're doing it well. So I think that's up to you. You can. We have no objections to that, as long as the process is done correctly.
Next.
Okay. Patient-centered care core criteria. We will look into that. If not in the actual standard, more on the what you call information to facilitate implementation of patient-centered care in the healthcare facilities. Next, Eman.
Okay, kita dah. I think we end the question. The question we can proceed. You can email to direct to MSQH email msqh@msqh.com.my, and we can also you can contact our staff for any further questions. Before we end, I just want to remind you about feedback. Please share the. Please do the feedback as in we put in the checkbox about this Survey Monkey, the link in the checkbox. Please do the feedback to we can continually improve our sessions. And other is in Facebook. I think they have also shared in the Facebook also. You can do your feedback in the Facebook. Okay. For us. And also videos will be available in Facebook, and the slides will be available in MSQH website. When you can check regularly, we will update it. So for this September training, I hope more of you if you want more details explanation on the 6 editions, you can go for the training. We will update in our website also, and we will email to our members for the training. So I hope before we end, kita akan buat consultation. We can do photo session. So siapa yang ada can open your videos. Wan ke PR yang manage untuk tangkap gambar ni?
Boleh ke? I would look like a dot.
Okay, siapa yang tangkap gambar ni? Wan. Okay. YTV tangkap gambar.
Okay. Ready?
Okay. Ready?
Okay. 1, 2, 3. Okay, wait.
Lagi.
Terus ada
kita ada 12. Okay, 12 kita buat 12 Okay, senyum dulu. Senyum lagi. Teruskan senyum sampai kita ketahuan. Okay. Kita nampak tak? Okay, 1, 2, 3, 1. Sekali lagi. 12 kali.
Okay, sekejap Okay, 1, 2, 3.
Okay. Kita move on to page 3. Page 3 Wan.
Okay, last one. Last one.
Last one. Okay.
1, 2, 3.
Okay.
Okay, last one. 1, 2, 3. All right.
Okay. Okay. Thank you so much for your participation. Don't forget to put your feedbacks. We will update. You can click the link in the chat room. Nanti boleh masuk balik chat tu. Link tu dalam chat room Zoom dengan chat room dekat FB. Please click, and we hope you can give a good feedback for us to improve our our sessions, and I hope you can be more people to participate in our 6th editions training yang the more detailed one. Okay, I think we end today. Thank you so much. Thank you for our speakers. Thank you for the participant. Okay.
Thank you. Assalamualaikum.
Bye.